For this voiceover, we're going to talk about acute kidney injury. Acute kidney injury ranges from a slight deterioration in kidney function to a severe impairment. It's characterized by a rise in creatinine and/or a reduction in urine output. Acute kidney injuries are potentially reversible, and they often follow a period of prolonged hypotension, hypovolemia, or exposure to nephrotoxic medications. So those are the medications that are harmful to the kidneys. This can develop over hours to days, and it's a progression of an elevated BUN, creatinine, potassium, and possibly a decrease in urine output. There's 3 areas this can occur: prerenal, intrarenal, and postrenal. First, we're going to talk about prerenal. So prerenal is caused by a decrease in blood flow to the kidneys. There's no damage to the kidneys with the prerenal phase, and the oliguria, or decreased urine output, is reversible at this point, so we can fix it. Patients that are prerenal have increased sodium and water retention and a decrease in their urine output. With prerenal, something is going wrong before the kidneys. So it's the heart, or the patient is hypovolemic or hypotensive, so the kidneys aren't getting the blood flow that they need. So with an intrarenal acute kidney injury, something is going wrong within the kidney. In most cases, it's due to direct damage to the kidney tissue. And the most common type of intrarenal AKI is acute tubular necrosis, or ATN. With postrenal acute kidney injury, it's most commonly caused by an obstruction of urine. So with postrenal, something is going wrong after the kidneys. So patients who have BPH, prostate cancer, renal calculi, trauma, or any extrarenal tumors, there's some sort of pressure that's not allowing the patient to urinate, so there's a blockage. So that urine is going to build up and cause an acute kidney injury. With acute kidney injury, it's important to understand the 3 different phases that patients are going to go through, the first of which is the oliguric phase. With this phase, the major sign or symptom is urinary changes. So patients are going to have a decrease in their urine output to less than 400 mLs a day. This phase will occur within 1 to 7 days of the initial injury to the kidneys, and it lasts about 10 to 14 days. If we were to do a urinalysis during this phase, we're going to see casts in the urine, which are made up of red blood cells and white blood cells clumped together. So some other signs and symptoms that we'll see during the oliguric phase are hypovolemia, which can make the AKI worse. With the decreased urine output, fluid retention is going to occur, so patients are going to have edema. They're going to have metabolic acidosis, sodium balance issues, potassium excess, so that hyperkalemia. They can develop hematologic disorders. The waste products will accumulate in their body, and they can also develop neurologic disorders. So the next phase that patients are going to experience with an acute kidney injury is the diuretic phase. In this phase, the patient's urine output is going to reach over 5 liters a day. The normal daily output is 1 to 3 liters, so they're going to have a huge shift from having less than 400 mLs per day to now having over 5 liters. During this phase, we need to be monitoring for hyponatremia, hypokalemia, and dehydration because they're going to be losing a lot of fluid. The last phase the patient will experience is the recovery phase. With this phase, the GFR starts to increase, which gives the creatinine and BUN a chance to decrease and go back to normal. This can take weeks to years for complete recovery to occur. In older adults, because they already have a frail renal system, they may never regain normal kidney function. With an acute kidney injury, the diagnostic studies that are important include a thorough history. This is the most important thing that we can do. Checking labs, so the serum creatinine, BUN, and GFR, and we can also check serum electrolytes. Getting a urinalysis to check for cells and protein. We're going to check urine osmolarity for sodium and other electrolytes, and we're also going to check a urine-specific gravity. We can check a CT scan, a renal scan, and a renal ultrasound. Above all, we need to identify the underlying cause so that we can fix it for these patients. So for collaborative care, the primary goal is to eliminate the cause of the acute kidney injury, manage the signs and symptoms, and prevent complications that can occur from an acute kidney injury. We need to ensure adequate intravascular volume and cardiac output, and we need to closely monitor the patient's intake and output and daily weights during both the oliguric and diuretic phases. When dealing with a patient who has an acute kidney injury, the most severe complication they can have is hyperkalemia, so that high potassium. There's a few things that you may see ordered for a patient with high potassium. One thing is giving regular IV insulin, and what that does is move the potassium back into the cells. And with the insulins, we want to make sure that we're giving IV glucose to prevent a drop in the patient's blood sugar. Along with that, we can see a sodium bicarbonate order, which is given to correct the acidosis and also cause potassium to shift back into the cells. We may see calcium, and what calcium does is increase the heart's threshold, so it helps to prevent any arrhythmias that can be caused by the high potassium. Lastly, you may see K-exolate, and K-exolate can be given either by mouth or by rectum, and it helps pull potassium into the stool so that the patient will pass it in their stool. With an acute kidney injury, if conservative therapies are not working for these patients, we'll need to begin renal replacement therapies like CRRT. Indications for starting that are volume overload, elevated serum potassium level that we can't decrease with the drugs that we mentioned before, metabolic acidosis, a BUN level that's higher than 120, a significant change in mental status, pericarditis, pericardial effusion, or cardiac tamponade. In regards to nutritional therapy for these patients, we need to make sure that they're maintaining an adequate caloric intake. In some cases, we do need to use parenteral nutrition to help. We need to make sure that they're restricting sodium and potassium, and we also need to make sure that they increase dietary fat and decrease dietary protein. The nursing management for acute kidney injury includes monitoring vital signs, intake and output, getting daily weights on these patients, examining their urine, assessing their overall general appearance, so looking at their skin color, looking for any edema, any neck vein distension or bruising. We're going to observe the dialysis access site if they have one. These patients don't always need dialysis with an acute kidney injury. Checking their mental status and level of consciousness, checking their oral mucosa, and that ties back into their hydration status, listening to their lungs and their heart, and also checking any lab values that are ordered. So along with what was mentioned on the previous slide, nursing management for an AKI also includes accurately measuring intake and output, checking daily weights. Remember that 1 kilogram equals 1 liter of fluid. Assessing for signs and symptoms of hyper or hypokalemia, carefully administering nephrotoxic drugs, skincare measures. So if someone is edematous, you have to make sure that you're taking care of the skin, preventing any breakdown, providing mouth care, regulating protein and potassium intake through the diet, scheduling and helping your patients get follow-up care, teaching them about ways to prevent another AKI in the future, or teaching them how to manage their AKI now, and any appropriate referrals. So we'll talk quickly about the geriatric considerations regarding an acute kidney injury. They're the most susceptible population, and that's due to the high frequency of dehydration, polypharmacy, so being on a bunch of different medications, the risk of hypotension, being on diuretic therapy, obstructive disorders like renal calculi or BPH, or having surgery or having an infection like a urinary tract infection.